Good. Good. Hey everyone, I know you got a short lunch break, and I really appreciate you taking time out of your day to come listen to me talk. I see a lot of familiar faces. I'll give you kind of a brief overview we're going to talk about. Probably 20 minutes. I want to be brilliant, brief, and be gone, and leave plenty of time for you guys to ask your questions, okay? So first I'm going to talk a little bit about like ketamine. So what is ketamine? Ketamine was first synthesized in the 60s in a lab. They were actually trying to find an anesthetic. They came up with PCP. Well, as you can imagine, it didn't work out so well. So they went back to the drawing board and made ketamine. Ketamine has been used in anesthesia. I use it to this day as part of my anesthesia practice. When we do it for mental health, it's a little bit different dosing, but it's been used for such a long time because it's very stable, very forgiving. And when I say forgiving, a lot of anesthesia drugs that we use brings your blood pressure down, brings your heart rate up, like you decrease respirations. Ketamine does the opposite of all of those things. Actually brings your vital signs up and increases respiratory drive. So using it in the clinical setting is very safe. I want you to put your mind at ease as clinicians. Your patients are in very safe hands and we're taking care of them. So it gained a lot of popularity in the 70s during the Vietnam War, 80s, 90s, and we use it in anesthesia practice today. My last deployment to Syria in 2017, that was the drug I used the most. I did full-blown anesthetics, belly open in a bombed-out building. Ketamine was a hero of the anesthetic. So how did we get to here? Like, how is it going to help your patients? So right around early 2000s, like 2005, 2006, they started doing some studies. They found that when ketamine is given in a sub-anesthetic dose, so what does that mean? So to put it in perspective, to talk about dosages, if you came in to get your knee worked on, let's say you're having a knee replacement, I'd probably give you 100 of ketamine. Hi, my name's Dr. Jeff, nice to meet you, all at once. And you'd go to cloud 9 and you wouldn't remember the rest of your week. When you come in for an infusion, it's at a much lower dose. Probably our range is between 30 and 75 milligrams for most males and females. What it does is it runs on a pump. So we start an IV on our patients, we put them on a monitor, we monitor their heart rate, blood pressure, oxygen saturations, and it runs over 40 minutes. During that 40 minutes, they get a slight disassociation. You're like, well, what does that mean? It's not like a Jimi Hendrix, Purple Haze, Lick the Walls. It's not like that at all. Like if you tap them, they'll open their eyes, they know who they are. But the best way to describe it is you become disconnected from your body. Like your hands feel disconnected, your feet feel disconnected. And we do a really good job of making sure that your patients are in a comfortable environment. They're in a lazy boy recliner, low lights, very low stimulus. We recommend an eye mask, headphones for that. Just want to make sure it's a very soothing environment. So how does it work? Like, that sounds real great. Everybody's like, I could go for some ketamine right about now. It's been a rough day. So that part sounds really great. So the way ketamine works, like functionally, if you imagine, can you hear me over this? Is that okay? I can talk, get closer and yell in your face. I'll do my best. 6 feet for COVID. No, I've got one. Do you want me to wear a mask? I'll put one on for you. Sorry, Carlos. So how does ketamine work? So if you can imagine like the brain as like a computer. You've got hardware, like stuff that comes in your laptop, and you got software, kind of what your hardware uses to run. So if you imagine the hardware of your brain, the structural component, ketamine actually does structural changes. Big fancy word is called synaptogenesis. What that means is, if you look at a depressed person, you teased out a neuron in their brains. A lot of times they don't have a lot of synapses on there. Synapses are the point where your brain sends a message from one part of it to another. They're decreased. Just after one ketamine infusion, if you were to do a functional MRI, you would see new buds of little synapses growing. You can Google this when we leave. I'm not just making this up. It's pretty impressive. So that's done by increasing BDNF. BDNF is brain-derived neurotrophic factor. It's basically like neuron fertilizer. It makes everything grow. So what that does is it allows your brain to kind of communicate differently, and then it also increases availability of glutamate. Glutamate is an excitatory neurotransmitter. So now you've got more places to send messages, and you've got more chemical messengers to send that message. So if you imagine your brain is like a city block with a depressed patient, half those lights are out, Ketamine's going to brighten everything up. And it's pretty fast. Like, it's the world's only rapid-acting antidepressant. Patients feel pretty good, like, even just with one infusion that day into the next day. They're starting to use it in the ERs these days actually as well. Like 0.2 milligrams per kilogram. Patients will come in with an acute suicidal attempt. They have data that says they'll give a single dose of it. It decreases suicidal ideations for up to 2 weeks. There's nothing else out there that's doing that. So that's kind of how it works on the hardware of your brain. On the software of your brain, like how do you view the world? When you get a ketamine infusion, your patients don't have to come in and be like, I want to think about this, or I want to think about that, or I want to work on this, or I want to work on that, or my uncle was a jerk when I was 6, and I really wish my husband would do the dishes more often. All that is done for them. Like, all they have to do is just sit there, relax, put their feet up. And you're probably wondering, like, does this work? Like, what? My patient's got severe anxiety. My patient's got OCD. My patient's bipolar 1, bipolar 2. It doesn't matter. The only things that I'm concerned about with patients is diagnosis of schizophrenia. Like, that's like the hero of their diagnoses. I've got patients who are like, schizophrenia kind of falls down a little bit. And I'm not too concerned about that. But if they're like diagnosed schizophrenic, hardcore, like, I don't want to trigger a schizophrenic event, and ketamine has been known to do that. But if you're at all questioned, you can always send them to me. It's free for me to talk to them. Dr. Jan or myself will talk to them on the phone. But during their infusion, the volume gets kind of turned down on the rest of the world. Like the Instagram, the Facebook, the Costco, the kids, the work, the mortgage, all of that stuff, the volume gets turned down. And they're left with what is. I know that sounds kind of like hippy-dippy, like Jerry Garcia, like being present in the moment, but it really is true. They're kind of left to think about some things that they weren't even aware. It's like, imagine like you get a ketamine infusion, you unscrew the back of your brain, and you're like, huh, I hadn't thought about that for a while, and they put it back on. And it doesn't always happen in the chair. A lot of times they'll go home and unpack these things for 2 or 3 days. So during their infusion, if something heavy comes up, some trauma or something like that, and they're not ready to go down that road, we keep the dose, most of the time, we keep the dose in a good spot where they don't have to go down there. That being said, we have patients with anxiety, severe anxiety that come in, you may be nervous about. I'm sure you've got that patients, they come in and they're just very, very anxious. When they come in with that diagnosis, we'll typically start their dose off a little bit lower, we'll run a little bit slower. And when they get their very first infusion, one of us is in the room 99.9% of the time. We'll sit right there next to them just to make sure that nothing is, they know they're being taken care of. After the second or third infusion, a lot of times people just want to put their headphones on, their eye mask, put their feet up and relax, and we'll let them be, and we'll just keep an eye on their vital signs. But in our clinic, it's very small. There's only 3 rooms in it. Like if someone coughs or sneezes, we can hear it all the way down the hallway. So it's like they're never not unmonitored. But during that infusion, it allows them to kind of disconnect from everything. If you can imagine like your patients who've got like trauma in their lives or depression, imagine it's like grooves in the snow. They have these thought processes they think of over and over, and the grooves get deeper and deeper, and they start to think about these things the same way. It's like, oh, this happened, so this is going to happen, this always happens. Ketamine kind of comes in, shakes up the snow globe a little bit, puts on a fresh layer of snow. So they know, hey, I can't erase that trauma. Whatever happened to them when they were a child or at war, I can't take that away. But what ketamine can do, it's like, well, maybe I can reevaluate how I view that. So we've seen really good results with that, especially with soldiers and trauma. And if you can get your patients in, this sounds crazy, but the closer to the trauma that we see them, like if you have someone who sees you like on a Thursday or a Friday and they've had an acute traumatic event, the sooner we can see them before the deep PTSD sets in, the better these folks do. So just keep that in mind. So what does an infusion look like? So kind of the process. If you think someone is a good fit for ketamine, they might be, might not be, you don't really have to like give it too much thought. You know who you're having a hard time with. You know who's not responding to traditional therapies. You know who could probably use a little bit more help. Have them give us a call. I'll talk to them on the phone, or Dr. Jana will talk to them on the phone. 30 minutes. It doesn't cost them anything. We'll answer all their questions, make sure that we've told them what's a good fit. And most of the time, like, other than like schizophrenia, uncontrolled high blood pressure, or tachycardia, or uncontrolled seizures, it's a good fit for most people. And you don't got to remember that. Like, if they call us and they have that, we'll take care of it. So don't trouble your mind on that. But those are the kind of things that we look for getting an infusion. So they call us, we talk for about 30 minutes or so, answer all their questions. If they sound like it's a good fit, we book them over the phone. They can either, that consult can be done face-to-face. Some people prefer to see us, see our clinic. We'll talk to them. Most people just want to do it over the phone. We'll talk to them on the phone. If they think it's a good fit, they book their appointment. It doesn't cost them anything to book their appointment. They come in, they pay for their infusion, they pay as they go. So like some clinics in town will want to charge for all 6 infusions. They want to charge for the consult. That's not our model. You pay as you go. If you like it and you want to keep doing it, you do it. They pay for their infusion, they come in. Crystal, our amazing nurse, where's she at? That's Crystal back there. We'll start the IV, or Jan and I will start it, but it's 99.9% of the time it's her. If you have patients who have needle phobias, they don't make needles any smaller. We use 24 gauge needles, which is what we would typically put in a neonate or a 1-year-old. We don't even use them in the operating room. So they're very, very small. It is a poke, but we have people that we've had to hold their hands and get through their first couple needle sticks, and by their 3rd or 4th, they're a pro, and they do just fine. We hook them up to an infusion. The dose is based upon weight. So whatever your patient weighs, we calculate their dose. And then we have a little bit of wiggle room based upon symptoms. We can move them up, we can move them down. It's very individualized. That's one of the nice things about ketamine versus like Spravato. I'm not a Spravato hater. If the statistics showed that it worked better, I would give it. Just right now, the bioavailability of it is like 50%. So you squirt some stuff up your nose, only half of it gets absorbed. Ketamine via IV is 100% bioavailable. And if we give it for an IM shot, it's 93% available. Most of the time we do IV infusions. They start their infusion, they put their feet up, head comes back, nice comfy lazy boy recliners, we turn the lights off. We recommend putting an eye mask and headphones on. If they're like very nervous, like PTSD or anxiety, we got room in the room for family members. Everything in our room is movable. We can push a chair right next to them, and they can, like a spouse can hold a hand, whatever they need. As long as that husband, wife, sister, brother, whatever, is additive to their infusion and not detractive. So you want to make sure that they're not making it harder. And what does that mean? So when a patient's getting infusion, we don't want to make them feel like we're all at a party and they're the only one that's high and we all know it. So we're not like, whoa, are you feeling it now? What about now? Because what that does to them is when they're getting their infusion, they're like, yeah, I'm feeling all right. Why is he asking me, am I feeling all right? Am I all right? How's my blood pressure? Am I hot? I'm going to be sick. It's like we want them to be as relaxed as they possibly can. And if they have, like, we've had a handful of folks that have had panic attacks. All we do is we stop the infusion. We'll let them catch up. One of the really great things about ketamine, it's very, very forgiving. So we'll stop the infusion. 5 to 10 minutes, they usually catch back up. They're not going to drive home, but they're with it enough. They're like, I think I'm okay. And we'll just slow their rate down. We book our infusions from door to door for an hour and a half. We actually only need from door to door usually about an hour and 15 to an hour and 10 minutes. But we always build that buffer in because we never want anybody to be rushed. So there's plenty of time for them to relax. And even if they go over their time, Crystal's like our timekeeper. She'll come in the room and be like, okay, Dr. Jeff, time to shut up. There's 3 people waiting. But most of the time, people understand that if they have to wait 10 more minutes, it's probably because someone had like a very emotional infusion or they're a little bit more tired. So I've never had anybody like really like, I need an eye infusion right now. It's like, people are very understanding. But that being said, we build that time in. So they get their infusion. It runs over about 40 minutes. When that infusion is over, it takes about 30 minutes to recover. They need to get a ride home. No driving for the rest of that day usually. But 30 minutes after their infusion, they start to get closer back to baseline. I mean, not a time to go make big decisions or financial plans, but they can walk, talk, go to the bathroom, text, continue their normal activities of daily living. It's not a good idea to go look at houses or buy cars because everything sounds like a good idea usually. And we brief all of them on this, so don't feel like you have to tell them this. We tell them everything. They finish their infusion, and when they come back, if they elect to come back, there's no like, gotta come back. Like if you feel like we're moving the needle for you, we want you to come back. But I don't want them paying for a service that's not doing them any good. It does most people good though. When they come back, I always like to talk to them, how have you been feeling? what does that mean? That sounds pretty arbitrary. Like, how are you doing? Like, I can get that from the barista at Starbucks. That doesn't tell me a whole lot. What I look for and what Dr. Jana looks for in crystalline waste is your overall mental health picture should be better. You're like, really? Like, are you sending me snake oil? Like, so like, I wouldn't just say it works for depression, PTSD, bipolar. Like, their overall mental health picture just gets better. Life should suck a little bit less. And what that does for you guys is like, if you've had patients as a therapist that you cannot get them to talk about something, like it's like you get to this point and you cannot make that breakthrough and it's just they're stuck there. You may find after a couple of infusions that, wow, you're able to move through some things, or maybe as your med manager, maybe we can adjust those medications and things are working better. And this is 100% what I'm saying here, like is 100% true. When a patient comes in, the first thing I ask them is, who's your therapist and who's your med manager? Those, you can ask anybody, because we have people who come in and they're like, oh, I'm just gonna get ketamine, I don't wanna take my meds, and I don't wanna talk to anybody. And I'm like, look, like I'm happy to do your infusion, happy to do it, but I always tell them it works best if we've got a team approach. I tell them, like, imagine there's a big log and all of us are carrying you. Like, I can't carry that log by myself over my head, just like your therapist and your med manager and your psychiatrist can't carry it. But if all of us hold it up and manage for each other, then we'll move in the right direction. So it's really important to me to have a team approach. So if you ever want to like talk to me about your patients who's getting ketamine, you can swing by our clinic. I'll be happy to talk to you. If you want to like delve into like doing some therapy during an infusion, we can talk about that as well. But the big thing is I want you to understand that this is a team approach. I don't want to work in a vacuum. The people that I see that do the best are the ones that have got good med manager and good therapist. Those are the folks who do really, really well because we're able to get a better picture of it. So when they come back, I ask them how they're doing. I get a lot of feedback from their spouses, husbands, sisters, brothers, whoever's closest to them. Because a lot of times from the inside looking out, we're like, oh yeah, I feel the same. Like I'm sure you've had patients who are like, no, nothing's changed since last month, my life still sucks. You're like nothing good happened in the last month? Like, come on, like there's gotta be something. So I'll try and gather feedback from their family as well. And I'll tell you a little anecdotal story. I had a patient who was on his third infusion and he was like, you know, doc, I don't think this is really working for me. And I'm like, really? Like not at all, nothing? And he's like, no. And his wife was sitting in the room. And she's like, are you out of your mind? And I'm like, every time I tell this story, I'm like, I can't believe she said that to him, to like a mental health patient. Like that's not the move, but those were her words. She's like, are you out of your mind? He's like, what are you talking about? And she's like, you were talking about suicide every day for the past 2 weeks. You haven't brought it up in 2 weeks. And he was like, oh yeah, you're right. He's like, well, maybe it is working, doc. So getting that feedback from other members, not just the patient, is really important to us. I've done consults with husbands and wives on the phone at the exact same time, so the wife or the husband doesn't have to tell the secondhand story, be like, you should have asked him this, 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 and this. So if you've got couples that are very tight, I'm happy to do that as well. So they come in for their follow-up infusion. I ask them how they felt during their infusion. Because it's important to me, like a ketamine infusion shouldn't be something that they don't look forward to. You should look forward to it. There's some clinics in town, it's like, they'll come in and they're like, how much can we give them? Like, just keep giving them more, keep giving them more. It's like, that's not always the move. Like, that's not what you want. More is not always better. So I want them to be a comfortable infusion, a slight disassociation, but I also want to get good results 2 or 3 days down the line, weeks. Because the goal is, the studies show 6 infusions over 2 to 3 weeks. I'm not draconian about that. Everybody's got different financial situations, different time situations. I recommend within a month if they can do it, but if people want to do it once a week, if people want to do it like however they want to space it out. I'm always like, I think some ketamine is better than no ketamine, and if they're like, I'm not getting the results I want, the first thing I say is, let's bring these a little bit closer to see if we can get better results. And we adjust their dose based upon that. So I'll start you off on your start dose, and if I feel like we're moving in the right direction, I might bring their dosage up a little bit. Small jumps, 5 milligrams, 10 milligrams. I want them to be in a comfortable spot. If at any time they're getting their infusion and they're like, yeah, number 3 was good, but number 4, that was a wild ride. I'm like, no problem. We keep track of all their dosages, we bring them right back. That being said, every infusion is going to be different for your patients. Like, it's not like a double Whopper with cheese. Like, you pay $5, you get a double Whopper with cheese, whether you get it here or you get it in New Mexico. Like, every infusion, they're going to be a collection of their most recent events. What's happened in the last 2 minutes, 2 hours, 2 days, 2 weeks. So, one infusion, they may touch the face of God. The next infusion, they may cry their eyes out. It's just, and that's a little bit hard to tell people because they're like, they think they're doing it wrong. They're like, my first one was so great, but the second one I just cried the whole time. I'm like, it's okay. It's like, there's some therapy there. Like, you're able to deal with some things and process some things you weren't aware of. So over the course of 6 infusions, we may have some highs and some lows, but we'll adjust our dose to keep them in that sweet spot. So where do we go from here? They usually finish their 6 infusions. When they finish their 6th infusion, we request they book a month out, 30 days. They don't have to pay for that infusion, but we have them put it on the books because our schedule is getting tighter and tighter and tighter. When we first started our clinic in October of 2019, we were probably doing 10 infusions every 2 weeks, maybe 10 infusions every 3 weeks. I was doing a lot of hiking, but now we're doing anywhere between 6 to 10 infusions a day. So we've grown exponentially. So I have them book that appointment so they're on the books. It gives them a good mark on the wall. Because what happens is their first 6 infusions are very structured. It's like you just march them out, boom, boom, boom. But I tell them, hey, a month out, it's gonna start to wax and wane. It's a treatment, not a cure. If they don't put that day on the books, then they might push it out to 5 weeks, 6 weeks, 7 weeks, 8 weeks. It's almost inevitably, if they don't book that appointment, they'll come in at 6 weeks and be like, Doc, I wish I would have come in 2 weeks ago. I pushed it out. And we might do an extra infusion, like maybe do 2 infusions to get them back. But I want people to get the most cost-effective treatment that I can. That's really important to me. And then they go into maintenance mode. Most people come in once a month to once every 2 to 3 months, but it's all based on their symptoms. Like in the summertime when it's nice like this, our numbers might go down a little bit because people go hiking, people get outside, people tend to feel a little more lifted. That being said, like I have people who are on a month like protocol, they'll come in every month, and then life might get hard. Death in the family, divorce, finances, they might come in every couple of weeks to get them through. My protocol is I don't recommend any closer than 2 weeks. If you start bringing them closer than 2 weeks, I mean, I've got 1 or 2 people who I inherited that were on a week protocol, and that's what's worked for them. And I'm not going to change their protocol. But you start getting too close, they start to develop tachyphylaxis, and then they start not getting the results that you want. We start bringing their dose up, and then you're chasing the dragon. What are we doing here? 2 weeks seems like a pretty good spot. Most folks are like a month to every 6 weeks. A little bit about our clinic, and then I'll close out because I know your time is valuable. Most of you know us. Our clinic's been open since October of 2019. Dr. Jan and I are pretty good friends with Dr. Weber. He asked us to come up here and Dr. Avalon started a ketamine clinic. He wanted to be more robust, so he came up here and made the ketamine clinic a little more robust. Dr. Jan and I both did over 20 years in the military. Jan is a doctoral prepared nurse practitioner. I'm a doctoral prepared nurse anesthetist. She's been in practice since 2004. 2004, I've been a CRNA since 2009. We've both been deployed overseas. We've provided care to those in harm's way under bad conditions as well as stateside. So you can trust that your patients are in good hands. 2 other key players of our clinic are Crystal and Wace. Crystal is our MA. Wace is our MA. So when your patients call, she'll be the person to talk to. She sets up all of our times, handles all the payments. I tried to do it when I first started and it sucked. Jolene did it for a little while and she realized it was too much to do, so we've got Wace on board now and she handles that. Crystal, I mentioned before, is our RN. She starts all our IVs, med management. The reason I want you to see our faces is if you see us in the break room or you see us around here and you want to curbside consult us, we're happy to do it. I may approach you in the hallway about your patient in a quiet environment. If you're like, I don't have time to talk right now, Dr. Jeff, push me aside, I'll send you a text. But I really enjoy that rapport. It's really important to me. I don't like operating in a vacuum. I don't like it when something's happening with a therapist and I don't know about it, like you're in a bad way and I don't know about it, or something happens during infusion, something really dark comes up. I want to make sure that someone who can actually unpack that, because people will tell me things in an infusion. I'm not a therapist. I do anesthesia for a living. We've done about 1,000 of these now, so I've gotten pretty good at listening. Maybe one day I'll become a therapist, but I'm not trained. The whole time I'm talking to people, I'm like, I hope this is the right thing to say. I don't want to send them in the wrong way. But what I've learned is if you're just kind, you listen, reflect, things tend to go pretty well. But yeah, that's pretty much my spiel. Any of that bring up any questions at all? Anything? Go ahead.
People that have strokes or TBIs?
Yeah, TBI, both fine. Strokes, the big thing for strokes is as long as their blood pressure is managed, because ketamine can bring it up. And if you've got a person who's got a stroke, just send them our way. I'll talk to them on the phone. I'll talk about meds. I'll talk about blood pressure. I'll talk about all that.
Can that help? So maybe it doesn't hurt, but can it help heal some of that?
So I don't have data on strokes. I've got data on TBIs. There's actually some neurogenesis and synaptogenesis that has been proven and studied. There's a couple of groups that are actually incorporating ketamine into their TBI protocol. So it's gotten some pretty good results. Actually, 10th group guys have done some studies on that. And we've talked a little bit about treating some of those folks for TBI. What's up? Oh yeah, good question. So yeah, I'll say it again. So something that we also treat with our infusions is we do pain infusions for patients as well. So what that kind of looks like, if you've got chronic pain patients, it doesn't really matter what kind of chronic pain they have, but if it's a debilitating pain disorder, we can do what are called pain infusions. All it is, it's a significantly higher dose and a longer duration. So for example, let's just say that one of your patients comes in and they get a mental health infusion. I might give them 50 milligrams of ketamine over 40 minutes. If they came in for a pain infusion, I'd probably give them 100 milligrams and then give them another 100 milligrams. So they'd get, it's a pretty deep dive. You're not driving anywhere for a while. I always recommend for those folks headphones, eye mask, because it's a pretty deep dive. That being said, I usually see about a 30% reduction either in pain or a 30% reduction in pain medication use, or a combination of both. So like maybe if they're taking Percocet TID, they go to BID. Or maybe if like they had to like reach into their meds earlier in the day, maybe they can push it down to later in the day and their pain is better. Or maybe their shoulder doesn't bother them as much. Or maybe they're able to like play with their kids a little bit more without as much pain. So that's something, if you've got chronic pain patients, you can refer to them us as well. We'll talk to them about that as well. As far as payment-wise, I should have mentioned at the beginning, our infusions are $250 each. I know that sounds like a lot. I wish we could bring it down, but we got 4 people on staff and lights to keep on. But if you do a Google search, even just in Colorado Springs alone, most places are $350 to $500, and they want all 6 of them up front, and they want to charge you for the consult. So you're looking at, there's a place in town right now, we've had people call us, just to shake your, or just to talk to you on the phone, you're looking at $3,500. You haven't talked to a doctor yet, and you haven't had a single infusion. And people have told me that it's hard to get their money back because they do if they do a few infusions and time commitments change or they're not a good fit, now they're fighting to get their money back. I don't believe in that. So a mental health infusion is $250, and a pain infusion is $500. It's not a premium for the pain infusion, it's just 2 infusions. So you took up 2 spots, so we just charge you for 2 infusions. So her question was, how long does it stay in your body? How long do you feel the ketamine, or how long if I drew your blood you would know? Yes, okay. So if you were to do a urinalysis, it would take about 3 days before it would clear your system. As far as like how you're feeling it, usually about 2 to 3 hours after their infusion, they're back into like maintenance mode. I call it dad mode for me, like because most of my patients have kids, and for me, I'm like, all right, when can I take care of my kids? Probably about 2 to 3 hours after their infusion. They're pretty much back to baseline. We don't recommend driving for the rest of that day at least, but if you've got activities of daily living you need to accomplish, probably a few hours after. What's up? I'll come to you. You stay there. Ketamine only lasts for 6 months. It actually only lasts probably about a month or so. So it's a treatment. So people will tell you they know when they're starting to feel, and then they'll come back in for an infusion. We'll give them another infusion, and we pick up their dose right where they left off. So whatever their 6th infusion dose was, that's where we march it out. So yeah, that is correct. It's not a cure. That being said, a third of antidepressants don't work for a lot of people. So 70-80% it works, not a cure. We're pretty happy with the results. Like I said, I'm not a trained mental health professional, but Crystal, Waze, Jana, myself, anybody who sees these people, like when you see them on their first infusion, I mean, I feel like I'm selling cars here, but I swear to God I'm not. Like when you see them come in on their first infusion, I've had people come in that are like, don't want to talk to you, like just that kind of like flat affect, or I'll talk to them on the phone. I'm like, I want to skip this whole consult. Like, just get in here and let me talk to you face to face, because it's like yes, no. I'm like, I'm talking to ER. I'm like, let me help you. But after the 6th infusion, most of the time they're like, hey, how are you doing? Crystal will be like, is that a new shirt? They're like, yeah, I got it last week, or like, I started hiking again. So I'm probably going to say this word wrong. Adhedonia, when you don't find pleasure in things, like people who, like for example, we have a couple people who paint, and if you come up in our clinic, I've got her picture up. She loved art, but she just wasn't. It became that stigma of like, oh, I gotta get the paints out, and I'm gonna make a mess, and oh, Jesus, is it even worth it? Now she's like painting pictures. She's bringing pictures in. So like after that 6th infusion, for the most part, like it's almost like a different person. Like I wish I could take like a little video like of your 1st infusion and of your 6th infusion. And that 6th infusion, I always tell them like, look, I want you to take a mental snapshot of how you feel right now. And I tell their spouse or brother or sister, like, I want you to like hold on to this. And when you start to drift off of this, give me a call. And it's usually within about a month they'll start to drift off. Some people, like I've had people drift off within 3 months, but it's different for everybody. But the answer to your question is, oh yeah, I mean, you can ask Crystal, like people who like, when they first come in, they're like quiet, and then by their 6th infusion, they're significantly more open.